Hello, good night. Welcome to all. We are very pleased to present this webinar about controversies in bariatric surgery. We have 4 outstanding presenters that I will present in just a minute. And also I will have the help of Carla Holcomb, that is going to be my co-moderator. Dr. Holcomb is an assistant professor at UT Southwestern. We are going to have Dan Herron, assistant professor of Duke University, Karen Gibbs, associate professor of surgery at Yale University, Yalini Vignas Baran, an assistant professor at University of Chicago, and Jan Soriano is an associate professor at University of California, San Francisco. So the topic that we are going to discuss today are controversies during bariatric surgery. And the controversies exist whether we should perform the single procedure, the primary procedure should be only the bariatric procedure, or we should add other unavoidable procedures like simultaneous cholecystectomy or simultaneous ventral hernia repair or simultaneous or concomitant liver biopsy. So I'm going to start with the first presenter, Yanili Vignes Baran from University of Chicago, that she's going to give us a first start with the high-yield summary of various bariatric procedures and discuss the pros and cons. So, Yanili, welcome.
Thank you. Let me get my screen shared here. And so, the topic I was given was a very high-yield overview here, and talking about the different surgical approaches to bariatric surgery. Thank you again for having me, and thank you all for listening at this time of night. I know it's busy for everyone. So just, quick overview. We all know about the obesity pandemic, and we understand how this is going to affect our patients and our patient care going forward in the United States, especially, this nice summary of the predictions of severe obesity in the coming years. By 2030, we really expect that almost 50% of adults in the United States will have and will suffer from obesity, and 1 in 4 adults will have severe obesity, as we define as a BMI of 35 or greater. And so this is a serious, clinical epidemic that's happening in the United States that is going to affect how we take care of these patients. As we know, obesity is more than just weight. We are talking about a lot of comorbid conditions with obesity that put significant weight on the medical community in terms of taking care of these patients, medical costs, hospital services, and whatnot. And so really, it's not just taking care of these patients for their weight, but also their comorbid conditions and this metabolic syndrome. And so thinking about surgery as a strategy to treat the metabolic syndrome, this is just a brief overview. I know we're all familiar with the different types of operations that can be performed for bariatric surgery and what we discuss with patients in terms of expected outcomes. I think there is some variation in what we discuss with our patients in terms of weight loss. And, I really believe, and I'm a true believer, that whatever the patient is most comfortable with, whichever procedure they're most comfortable with, is what they're going to be most successful with. And so here we have some estimates on what most of us will tell patients in terms of what to expect in weight loss. The gastric band largely not placed anymore. And so the gastric bypass sleeve and the duodenal switch are really the procedures we'll be talking about. And even when talking about the weight, we talk about these comorbid conditions and the metabolic syndrome. Gastric band has really been off our radar for quite some time now, obviously from the side effect profile and complication risks with that, as well as the ability to maintain weight loss after this procedure, but also because its impact on the metabolic syndrome. And we know that, as you can see in this nicely done review, that the Roux-en-Y gastric bypass as well as duodenal switch do result in much higher rates of resolution of diabetes, hypertension, hyperlipidemia, and in fact, just weight loss itself. But the topic that I had been charged with was not to compare the different types of operations, but to talk about the surgical approach. And so when we talk about this, I want you to keep in mind what when that first slide talking about how obesity is going to be changing in the next 10 years and be affecting many more patients. And so really it's a matter of access to care. And so the topic I was given was approach, open versus laparoscopic approach. I know that largely looking at the MBSA-equipped database now, that bariatric surgery is largely done laparoscopically. But if we're talking about access to care and making sure that the patients who need this operation can get this operation, we also have to address whether open approach is appropriate. And so I think most of us can talk about what the differences are between open and laparoscopic surgery, but looking at the data, this was a nice systematic review looking at 6 randomized controlled trials and a total of 510 patients comparing laparoscopic to open approaches for these patients. And what we see that actually when we look at all-cause mortality, it was similar between the two groups. There was no difference in mortality, whether it was done laparoscopic or open. And similarly, if you looked at anastomotic leak, there was no significant difference whether the patient had the operation done open or laparoscopic. And I think those are, you know, the most important outcomes when we're looking at this, but there's several other outcomes we need to investigate as well. Wound infection, this shouldn't be a surprise to most of us because this is a trend we see in a lot of different types of operations when we talk about an open approach to laparoscopic approach, especially in our patients suffering from obesity. There is a much higher risk of wound infection in patients that had undergone an open approach as compared to a laparoscopic approach, and this was significant. And additionally, not a surprise here, there's a significantly higher risk of incisional hernias after an open approach. So, you know, thinking about open versus laparoscopic, I think it's important to know that open surgery is still safe, but there is this side effect profile that we need to be aware of. And so this kind of brings me to a little bit of an off topic that will be interesting in the discussion to talk about, but why, you know, open surgery still remains common in the US. This is a little bit older data from 2015, looking at urologic and some general surgery procedures. And you can see that, you know, urologists have largely moved to robotic operations and doing a small portion open, very little laparoscopic surgery. Gynecology is really a mix. Colorectal, and I'm sure this number has changed in the last few years as well. Still a large percentage of patients undergoing open operations. Ventral hernia definitely has changed in the last couple of years with the advances in robotics. And then thoracic surgery. And I put this slide up just because I wanted to point something out. If you look over here at the urologic procedures, and sorry, gynecologic procedures that are largely done robotic, if you look even 10 years ago, these were all procedures being done open. Now these procedures are being done robotic. And so I wanted to introduce the topic of a robotic approach, especially if we're talking about surgeons that have not been trained in advanced laparoscopy to be doing bariatric surgery, but are needing to provide bariatric surgery services for their patients. And so I think it's fair to say open surgery is safe, but what about robotic surgery? This was a nice paper looking at the recent, I guess not so recent, 2018, but recent trends in robotic surgery and how they've been changing in bariatric surgery itself. And looking from 2015 to 2018, the percentage of robotic surgery has actually slowly been increasing. And so in 2015, looking at 260,000 bariatric cases, and these were primary bariatric surgeries, 5.8% of those were robotic in 2015, and that was increasing up to 9.4% in 2018. I would hypothesize that in 2021, that percentage is much higher, as a lot of us have started adopting robotic surgery in our practices in general surgery in general. And with the advances in the surgical robotic technology, this probably will continue to grow. And so with the rise of robotics and, this need for access to care for bariatric patients all across the country, I think there's going to be a rise in this robotics and bariatric surgery. One, I think with the competitive robotic new platforms that are coming to market, that's definitely going to help reduce prices and probably push the technology even further. The new technologies that have come out with Intuitive specifically, but in robotics, talking about the Sureform stapler and our stapler technology that's available on the robot now. I think especially when we're talking about bypasses and duodenal switches is really going to push robotics forward. And then as we see increased availability in hospitals, I think all of us can say that we've probably seen more robots around over the last few years. And I think that will continue to be the trend. And so just to summarize, these points, and so that we can have some discussion about surgical approach after everyone's given their talks, but access to bariatric surgery needs to increase given this obesity pandemic. Open approach remains safe to perform. And I think if that's what you can offer your patients is an open bariatric surgery, it's still a safe operation to perform, and it's better than no operation. However, it's important that patients and providers are aware that there's an increased risk of wound infections. There's probably an increased, or there is an increased risk of incisional hernias down the road that these patients will have to manage. And then lastly, and this is probably a point of more contention than others, robotic techniques may allow for better access to minimally invasive bariatric surgery. And I'd be interested to hear even from my co-panelists here who's doing more robotics in terms of bariatric surgery. But I think that conversion from open surgery to robotics is a much easier transition. We've seen that over and over again in so many specialties. And I think it's important to keep an open mind to that as well. And then lastly, for anything to be safe, definitely need to have a great team. This is my team. We have a great bariatric surgery team, and it's not just the surgery itself, it's the preoperative and postoperative care that's the most important for these patients. And so a lot of the success is actually due to our team of our vast team that takes care of these patients. And I'll leave it at that. Thank you.
Thank you very much, Yanili. Excellent presentation. So I want to remind the audience that to have a good flow of the webinar, we are going to do first all the presentations, and we will welcome any question you may have. I invite you to use the Q&A button to use for any questions that it will be answered at the end of the webinar. So I will present the second presenter, Dr. Yan Soriano, an associate professor of surgery at University of California, San Francisco. He recently moved there, and he's going to present another very controversial topic, that is bariatric surgery and concomitant cholecystectomy. So Yan, welcome.
Thanks, Sergio. Let me just share my screen. Right, can you guys see the?
Yes.
Can you guys see the screen now?
Yes.
Awesome. Good. Excellent. Good evening, everyone. Thank you very much for joining our webinar, and thank you to SSAT for the invitation to speak today. I'm going to talk about the still ongoing controversy about concomitant cholecystectomy in patients undergoing bariatric surgery. I have no disclosures relevant to this talk. So what I think some of the questions that really are important to ask are, what is the role of screening ultrasound in the asymptomatic patient undergoing workup for bariatric surgery? Secondly, what are the risks associated with concomitant cholecystectomy? I think that is the question that we really want to find out. Is it safe? And what is the evidence for that? And then lastly, I guess the other reason why we are thinking of whether or not we should do cholecystectomy is, what are the risks if we leave the gallbladder in, especially in patients who are undergoing gastric bypass or duodenal switch? Specifically, the risk of future gallbladder surgery, and of course, the risk of choledocholithiasis or cholangitis. And at the end, we'll talk a little bit about the role of orsodiol. So these are probably some of the more common presentations that surgeons will see in their clinic. You'll see a patient scheduled for a gastric bypass who's undergoing workup and is found to have cholelithiasis on screening ultrasound, or found to have ultrasound on cholelithiasis on prior ultrasounds. And this patient just happens to live 2 hours away, something that we see commonly here at the University of California, San Francisco. Another typical presentation would be a patient, BMI 55, scheduled for a DS in about 3 weeks, calls you with right upper quadrant pain as they start with their pre-op diet, and ultrasound shows cholelithiasis, but he is tolerating PO intake. And of course, there's the patient who is scheduled for another gastric bypass in about 5 weeks, and then comes to the ED with her third episode of biliary colic, but still able to tolerate PO. How would the audience manage these patients? Hopefully at the end of the talk, we'll maybe have some consensus on how to approach this. The reason it's important is because we know that obesity and gallbladder disease are intertwined with about a 5-fold risk for gallstone formation in patients with obesity. After surgery, rapid weight loss increases the risk of developing symptoms. And cholecystectomy is the most commonly performed procedure after bariatric surgery. If done preoperatively, as we know, it may be more challenging in an obese patient because of fatty liver or visceral fat. One of the significant restrictions or limitations of ultrasound as a screening tool is that it is less accurate in patients with obesity, particularly patients with a lot of central obesity. We know that in patients with obesity, only about 8% are seen, but then after surgery, about 10 to 40% develop stones. However, despite these numbers, of that percent, only about 3 to 10% of patients progress to symptomatic disease, regardless of the procedure that they undergo, from band to sleeve to bypass or duodenal switch. And majority of these patients who become symptomatic are able to be done laparoscopically, as they are uncomplicated. Based on that data, and I'll show the references at the end of this talk, we still at this point would not recommend screening ultrasound for patients undergoing evaluation for bariatric surgery, regardless of the procedure that they are having. What about the risk of concomitant cholecystectomy? And let's just say a patient already presents with an ultrasound, and surgeons decided, still thinking about whether they should do concomitant cholecystectomy in these patients. So several papers have come out since 2012, 2015, and more recently 2020. Found that about 2 to 3% of patients undergoing bariatric surgery undergo concomitant cholecystectomy for a variety of indications. Unfortunately, most of the papers are reviews of MBS-AQIP, so there are no distinctions between what was the actual indication for surgery. Warney in 2012 looked at the national inpatient sample. The group here at UCSF, led by Wood, published their results in 2019, looking at the MBS-AQIP data from 2015, as well as Clapp, published in obesity surgery, look at the MBS-AQIP from 2015 to 2017, found that for concomitant procedures, there was actually an increased operative time ranging from anywhere from 21 to 50 minutes in these studies, with a slight increase in morbidity, particularly in patients who underwent surprisingly sleeve gastrectomy, both in terms of SSIs, as well as readmissions, reintervention, and even reoperation. What was interesting is that they did not find, none of these studies found any increased risk for patients undergoing a Roux-en-Y gastric bypass. As we know, in gastric bypass patients, as well as the early 3 to 6 month period after a sleeve gastrectomy is when the period of rapid weight loss happens, and this is where there's an increased risk for symptomatic disease. Papers have shown that the highest risk happens between 6 to 12 months, and mostly, for the most part, returns to baseline at 36 months post-op. Even with that risk, only about 2 to 10% of patients who've had a sleeve gastrectomy or Roux-en-Y gastric bypass undergo cholecystectomy. And again, as I mentioned earlier, the majority is for uncomplicated biliary disease. The advantages of waiting and not doing concomitant cholecystectomy at the time of the initial procedure is that once the patients have lost weight, there is less visceral fat, and the liver is much easier to elevate due to decreased fatty liver disease. The other risk that surgeons consider when thinking about a concomitant cholecystectomy is what is the risk of choledochilothiasis that may lead to cholangitis after a Roux-en-Y gastric bypass. Studies have shown that this risk is actually very small. It's anywhere from 0.2 to 5% risk of developing choledochilothiasis after gastric bypass procedure. But again, the worry is that we don't necessarily know the limb lengths of these patients. I think the very important thing to consider here is what is the availability of expertise in your area. Because the SAGES published these guidelines in 2020 showing the various options available. And it is very important for surgeons in their area to see what is available. Whether you have access to skilled surgeons with who can perform a laparoscopic common bile duct exploration, interventional gastroenterologists who can perform a balloon ERCP, doing a combination procedure with a laparoscopic transgastric ERCP, as well as interventional radiologists who can do a percutaneous transhepatic biliary drainage. I'm going to speak really very briefly about the EDGE procedure, as this is something that has been described a little bit more recently. It was first described in 2014. EDGE stands for endoscopic ultrasound directed transgastric ERCP, where the gastric remnant is accessed either via the gastric pouch or via the alimentary limb, where upon finding the remnant under ultrasound guidance, a lumen opposing metallic stent is deployed, and either at that same procedure or much later, ERCP is performed across the stent. Once the procedures are completed, then the stent is extracted, and various modalities have been used to close the purposely created gastric fistula or jejunogastric fistula, either through argon plasma coagulation, endoscopic suturing, use of an over-the-scope clip have all been described. Currently, the longest follow-up for these patients has been between 6 and 12 months. So I think that there's still a lot that we need to know before we can consider the EDGE procedure as something that will have long-term use. The way I see this would be in patients with a frozen abdomen, where there's no way to do any procedure laparoscopically or any type of minimally invasive approach. So for patients undergoing a sleeve gastrectomy or Roux-en-Y gastric bypass, the current recommendation, at least based on what we've seen, is that it is not recommended, but for patients who do need a cholecystectomy for various reasons, it can be safely performed, knowing that patients who undergo sleeve gastrectomy with concomitant cholecystectomy might be at slightly higher risk of morbidity. Moving forward to patients who undergo a duodenal switch, one of the challenges is that there is loss of the gastric remnant for access, as well as the presence of longer limb lengths with varying biliopancreatic limb lengths depending on the common channel length. Paper written by one of our hosts today, Sergio Bardaro, in 2007, showed that only about 8% of patients after duodenal switch required a cholecystectomy after a duodenal switch, and they said that a concomitant cholecystectomy is not necessary. This was also the conclusion reached by Secondi in obesity surgery in 2016. What was interesting is that approximately 38% of their patients who had a duodenal switch developed biliary symptoms after the procedure, of which and 51 of the patients underwent cholecystectomy, with 2 being done open and 1 patient requiring an open common bile duct exploration. That paper's conclusion is that there is an acceptable risk of biliary pathology after duodenal switch. I will stress that in both studies, patients were placed on ursodiol for 600 milligrams daily for 6 months. For patients who are undergoing duodenal switch, please consider available local expertise in terms of not just a surgeon, but also interventional radiologists. And also, finding of asymptomatic stones in ultrasound is not an absolute indication for a cholecystectomy in patients who are undergoing a duodenal switch. And it is very important for these patients to be placed on ursodiol. Last but not least, I want to just show a brief slide on urso, since we know that about 10 to up to 40% of patients may develop de novo gallstones. For those who are unaware, urso comes from the Latin word bear, because ursodeoxycholic acid is the predominant bile acid in bears, and it has been produced synthetically since 1950. A recent paper that came out called the Upgrade Study, which was a multi-center, double-blind, randomized, placebo-controlled superiority trial, enrolled patients with an intact gallbladder scheduled for a laparoscopic gastric bypass or duodenal switch, was performed in the Netherlands. And patients were randomized to one of 2 groups, and one group was placed on 900 milligrams daily of orso for 6 months. The biggest benefit of orso was seen in the subset of patients who underwent gastric bypass surgery who did not have any stones on screening ultrasound. There was not enough difference in patients who underwent sleeve gastrectomy to make a conclusion. So in summary, screening ultrasound is not recommended for any patient undergoing any type of bariatric procedure. In terms of concomitant cholecystectomy, definitely for any of the procedures, it is not recommended. Especially, you have to consider that there might be a slight increase in morbidity for patients undergoing a sleeve gastrectomy. However, in patients who are undergoing a Roux-en-Y gastric bypass, even though cholecystectomy is still not recommended, there is no increased morbidity, so it is a safe procedure to perform in this patients. Obviously, taking into account the skills of the surgeons who are performing this, as most of these patients oftentimes will present not to the same institution that did the initial procedure. Lastly, in patients undergoing duodenal switch, we still do not have enough data to make a formal recommendation. However, it is very important to just make a discussion between the surgeon and the patient. Going back to our case presentations earlier, for the first patient, this is a patient who probably you can consider doing a simultaneous cholecystectomy at the time of a Roux-en-Y gastric bypass, or the patient can be placed on ursodiol for the first 3 to 6 months. For the second patient, since the patient is still able to tolerate PO, then this patient can probably be handled by undergoing a simultaneous laparoscopic cholecystectomy and duodenal switch. And for the patient in the last scenario, who presented with a third episode of biliary colic and is able to tolerate PO given the time difference and the frequency of symptoms, it's probably best to admit this patient, perform a laparoscopic cholecystectomy, and proceed with the gastric bypass in 4 to 6 weeks. These are the references for the presentation, and I thank you so much for your time. Have a good day. Thank you.
Thank you, Jan, for your excellent presentation. Very good. It was very informative. We are going to continue with our next presentation. Is Dr. Karen Gibbs. Karen is the chairman and associate professor of surgery at Yale University School of Medicine at Bridgeport Hospital. She's going to present also another topic that exists a great debate, that is simultaneous bariatric surgery and concomitant ventral hernia repair. Karen, welcome.
Thank you, Sergio. I'd like to thank the SSAT for the opportunity to present in this forum. As we are talking about the consideration and concomitant hernia repair. So obesity predisposes us to a myriad of metabolic derangements that we are very well aware of. But sometimes we spend less time talking about the anatomic pathology in the form of abdominal wall hernias that our patients must suffer with and must be addressed. According to the literature, approximately 8% of our patients will have ventral hernias at the time of their metabolic and bariatric surgery. What causes these hernias and the predisposition to it? Well, our patients are living sometimes with chronically elevated intra-abdominal pressures for extended period of time, whether it be from visceral adiposity or from the thickness of the abdominal wall. And this leads to our patients having higher risk for larger hernias, multiple hernias, as well as laxities of the abdominal wall. They are at increased risk for incisional hernias, surgical site infections, and often very challenging to repair and have an increased risk of recurrence. So the fundamentals, we know bariatric surgery is the most common and effective manner for dealing with the problem of obesity. And generally the teaching is that we try to lose weight or have our patients lose weight before we would approach the hernia repair. But we have a significant number of our patients which will pose this particular therapeutic dilemma because they are presenting with two health problems with a surgical answer. So which one should we do first, or should we do it concurrently? And timing obviously is essential. Obviously, if our patients present with strongly symptomatic then they should be undergoing their ventral hernia repair prior to surgery, but this then also brings up the issue of the potential risk of the bariatric procedure after a ventral hernia repair has been provided. So the discussion of concurrent repair is what we're going to spend our time with, but also going to discuss the choice of having a delayed repair. Each one of these has advantages and drawbacks which should be considered. So what does the literature say? Well, there are lots of things out there. The controversy is still strong. There are lots of conflicting opinions that exist about the safety and success. So we'll review some of the studies that speak to the success and risk associated with concurrent repair, review some of the registries that are now available to us, as well as just discuss the expert consensus guidelines that are available. Well, certainly the argument for concurrent repair is that it's one operation, it's efficient, it avoids a second operation. And really, sometimes we have no choice because depending on the level of dissection or the extent of the dissection that needs to be done, it is really what would be necessary to facilitate the successful completion of the procedure and then deal with the risk of post-operative hernia complications if those fresh edges would then be the nidus for adhesive disease and potential complications. So we do have Eid et al. Who reviewed 85 patients who underwent concurrent repair, and they divided their patients into 3 groups. Primary repair, which the abundance of our patients underwent. Then there was a biomaterial that was utilized, and then there was a group of deferred that was left with a deferred repair. You can see the hernia sizes were variable, and a good number of our patients in this study had incarcerated hernias. Ultimately, the major teaching point from that paper was that for those patients who were left with a deferred plan, 36% of them quickly presented with a small bowel obstruction. Obviously, in the setting of a recent bariatric procedure, this is potentially challenging as you then face concerns with anastomotic leaks or staple line disruptions as a result of the small bowel obstruction. Now, there are a number of small to moderate sized studies that speak to concurrent repairs. And this study used the NSQIP database, had a very extensive number of patients, 27,000. And in this group, 3.6% underwent concurrent hernia repairs. That really was 988 patients. And in a one-to-one matched analysis, there was an interesting group of findings. A couple of things I thought was good about this paper was that oftentimes we think that the hernia repairs are always going to be laparoscopic as well. But you can see that in this study, in this review, a third of the patients underwent an open repair. And most of these hernias were reducible, with the minority being incarcerated or strangulated hernias. The primary outcomes of the procedures were interesting in that we saw, that the gastric bypass and for the sleeve gastrectomy, there was an increased risk in terms of 30-day readmission and reoperation for the gastric bypass, and really the composite adverse events were larger in the gastric bypass. For the sleeve gastrectomy, we found that we had an increased risk in terms of readmission and reoperation. And in the text of the paper, they really stated that smaller hernia defects and those that are manipulated during the index bariatric procedure are at risk for incarceration and strangulation in the immediate perioperative period. And such probably should be addressed concurrently. Another database that we use, the MBSA-QIP database, also looked at this population with short-term outcomes. And what was found in the composite was that we had increased risk of readmissions, reoperations, surgical site infections, as well as sepsis. In this review, only about 1% of the patients underwent concurrent repair, which was somewhat interesting because as you would recall, the estimated prevalence was about 8%. So is it that we're just not addressing a significant number of patients who have these hernias and just choosing to defer? So in the aggregate for the MBSA-QIP cohort, readmissions and reoperations were increased with concurrent ventral hernia repair. The operations performed were incision and drainage, enterolysis, and enterectomy, as well as recurrent hernia repair, even in the short term. And in the setting of enterolysis and enterectomy, one would assume that there was some operation done to manage intestinal obstruction in this setting. When the data was stratified by procedures, you can see that the sleeve gastrectomy had a higher rate of reoperation. The gastric bypass, on the other hand, had a higher rate of reoperations, readmissions, and major complications were just higher overall. So what is the best approach? As we said before, there you can do a primary repair, a mesh repair, whether it be biologic or a synthetic, and there's a great deal of information out there that speaks to this. From a primary suture repair approach, it's lower cost, it's a shorter operative time, but the risk of small bowel obstruction is not negligible at about 3%, and it has the highest rate of recurrence. Now, some have recommended the use of biologic mesh. After all, we're working in a setting of a clean, contaminated procedure, but we do know that biologic mesh are very expensive, and amazingly enough, the recurrence rate, as expected, is significant. So is the benefit worth it? Synthetic mesh, however, has now also garnered a large amount of research in respect to it. And most of the research shows a low rate of recurrence and limited complications in the setting of small bowel obstruction. What I thought was interesting, a nice study that was done by Kozakov et al. With the Raul Rosenthal group, is that they examined peritoneal fluid in cultures in patients who were undergoing bariatric surgery. Primarily the sleeve gastrectomy and the gastric bypass patients were used as the other cohort. The patients prior to, once the laparoscopic access had been gained, the cultures were taken for all of the procedure, for all the patients, and the pre-procedure cultures were all negative. For the sleeve gastrectomy, all of the post-procedure cultures were also negative. And for the gastric bypass, 15% of those patients had positive cultures. So overwhelmingly in the setting of sleeve and gastric bypass, the cultures that were taken immediately at the end were negative. And there have been a large number of studies, mostly single institution or single surgeons and small groups, which show that there were no issues with infection with the concurrent ventral hernia repair with mesh in gastric bypass patients. So we come to our consensus statement, which was a collaboration between the ASMBS and the American Hernia Society. And basically they're stating that if both procedures can be performed laparoscopically, a single stage approach may be safe with good short-term results. If, however, the ventral hernia is not amendable to a minimally invasive approach, a staged approach in this setting would be recommended. They do state in this paper that there is noted to be a lack of strong evidence in respect to synthetic mesh in this setting. So not all hernias are equal. Size, location, primary, recurrent, when they become more complex, where the integrity of the skin is compromised, loss of domain, and people who you may be looking at doing an abdominal wall reconstruction, as well as the approach that is going to be used to repair the hernias, all these things must be taken into consideration. So we have the fundamental understanding that obesity predisposes to abdominal wall hernias of lots of size and flavors. Strongly symptomatic patients should be addressed expediently. Small hernias discovered at the time of surgery, it is really recommended that those should be addressed to minimize the risk of the immediate postoperative problems. However, concurrent ventral hernia repair does increase perioperative morbidity. And this occurs for both the sleeve gastrectomy and the bypass, but more so for the gastric bypass. Thankfully, it is not associated with a greater mortality, but this debate will continue because variability in patients and hernia characteristics certainly requires that we have a thoughtful, individualized approach to our patient care. Thank you.
Thank you, Karen. Again, excellent presentation, very interesting data. And now we are going to go to the last but not least of our presenters is Daniel Guerin, Assistant Professor of Surgery at the Duke University School of Medicine. Dan is going to present bariatric surgery and simultaneous liver biopsy. So Dan, welcome. You have the podium.
Good evening. Thank you, Dr. Bardaro. This is a privilege to be here. Thank you for joining today. I'm presenting bariatric surgery and simultaneous liver biopsy. These are my disclosures, none of which are relevant to the topic today. What's the problem? So the problem is that we have this liver disease that is very prevalent in obesity, and is classified as the non-alcoholic fatty liver disease, which is the leading cause of chronic liver disease and carcinoma in the liver. And it's the second leading indication for liver transplant in the United States. This has a severe form, which is NASH, the non-alcoholic steatohepatitis, which presents with inflammation and leads to fibrosis in the liver. The problem is that when you have NASH, that puts you on increased risk of progression to cirrhosis and liver failure. And NASH is associated with increased morbidity and mortality from cardiovascular disease, cancer, and complications from end-stage liver disease. So it's a bad problem. And it goes in hand with the obesity epidemic that we have. The overwhelming majority of the patients that undergo bariatric surgery already have some sort of fatty liver disease. It was noted in some studies that about 88% of the patients have this disease at the time of surgery, 75 of whom have NASH or the severe form of the inflammation. About 9% of these patients will have an advanced stage 3 fibrosis of NASH in 9% of the cases, and about 2 and 4% of these patients. So it's a very, 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 very bad problem. The good news is that we have the best tool available to treating this disease. And bariatric surgery has been documented throughout retrospective, prospective trials that is the best option to treat this condition, to the point that we know that it can decrease the incidence of NASH in about 84% of the patients, and it's correlated with the amount of weight loss, as you can see in the bar graph on the screen left. And recently, Dr. Aminian from the Cleveland Clinic presented a retrospective cohort of almost 1,200 patients in which with biopsy-proven NASH without cirrhosis, that bariatric surgery is significantly associated with a lower risk of major advanced liver outcomes or MALO, with an absolute 10-year risk difference of 12.4%. And not only that, but also will influence in the major cardiac events. So putting everything together, it seemed like the bariatric surgery is the right operation for liver disease and other conditions. But it's really, really hard to diagnose. And to that end, we're going to discuss the role of biopsies, but also we need to understand that there are non-invasive tests available. Unfortunately, this test, they're better to ruling out than ruling in the severe fibrosis or cirrhosis. And we rely on serum biomarkers or things that estimate the liver stiffness. We have transaminases, we have several scores that are depicted here in the slide, or we have the transient elastography, and even some MRI new technology that we're using now to see the effectiveness of treatments, but still not as reliable as what people consider the gold standard. And it's very hard to diagnose, especially when you're in the OR. And most of my colleagues here have encountered these beautiful livers, most of them bumpy, most of them with fatty infiltrations, most of them very large but looking normal. And then you don't know what to do. You don't know if you should biopsy all of them. You don't know if you need to biopsy them with indications. And that is exactly the controversy that we're going to try to address today. So we know in studies in which they've asked the surgeons to examine the macroscopic appearance and the tactile examination of the liver, and then give an opinion or a objective diagnosis related to this appearance and see if the patient has some sort of liver disease. But we see that that does not correlate well, has a very low sensitivity, low specificity. The predictive value is around 5%, and the negative predictive value is 80%. So the eyes of the surgeon in certain studies are not the best to diagnose NASH. Therefore, some people postulate that we need to use biopsy. As a matter of fact, in the second paper by Dolce, published in SWORD, they did a similar study in which they asked the surgeons to assess the liver appearance and then compare it with the histopathologic findings, and they found that there were some diagnoses that they were missed, and then they labeled the intraoperative liver biopsy as safe, and it has to be a mandatory type of event. And when you discuss biopsies, it's very controversial because you need to have a very, very good method to biopsy the liver. You can do core needle biopsies or wedge biopsies. In terms of core needle, you need to have certain characteristics in order to have this a reliable sample. And then there's comments about the wedge biopsy that, you know, because they're close to the glycine capsule, they can upgrade the classification and over-diagnose fibrosis. But also, the essence of this talk is, when do we do it? Do we do it selectively, or we do it as a routine? But we need to agree on one thing. The risk of a liver biopsy is exceedingly low. If we do this percutaneously, is around 1%, and that liver biopsy done laparoscopy, whether you use a direct visualization with a percutaneous access or a wedge, it's very, very low. It's 0.2% up to 1%. But if we consider that we're doing 256,000 procedures, and that was the latest data from the ASMBS in 2019, we're talking about, you know, a significant amount of procedures that can get complications. But also we need to consider that it adds time and cost to the surgical procedure. It has been demonstrated that it's exceedingly safe in this study using the MBSQIP data by CLAP, in which they did around 20,000 biopsies, and it's labeled as a safe, but adds operative time about 18 minutes per case, but does not increase the length of stay, the bleeding complication, morbidity, or death. So up there, biopsies are safe and can be done. Now, should we do it routinely or should we do it selectively? In this paper, using a retrospective cohort from New Zealand, they used 135 patients, and they identify 89% of liver disease with up to 9% of fibrosis stage 3 patients that require referral to a hepatologist for follow-up. No complications. And they postulate that without doing a routine biopsy, you would not identify almost this 10% of bariatric patients that would require a referral. That was their argument. The same thing in this paper just published in Obesity Surgery, in which they compared patients with routine biopsy and selective biopsy. And they're postulating, as you can see the numbers here, that if they wouldn't done that biopsy, you will miss a great amount of patients that need a referral for medical management and a longitudinal surveillance. So these papers are comparing the routine liver biopsy. But when you go and read a little more on these review papers, there's other authors that say, listen, we are screening biopsies. They're not recommended in the obese patients in general. Why are we doing this in only patients that are doing bariatric surgery? And at the same time, why are we doing these follow-ups in patients that are already getting an outer course of the disease? So we cannot even study as a disease model. The complications exist, but they can go up to 2%. They add time and cost. And most of the routine biopsies are not endorsed by major hepatology societies. So why are we going to do this routinely? This guy, Mahawar, postulates, let's do this selectively. Interestingly, there's a paper on adolescent bariatric surgery that asks the same question, and using a very interesting approach in which they compare bariatric surgery in two different time periods in which they seem to have a change in their way of thinking. They postulate by looking at the numbers that while routine implementation of the liver disease was found only in half of the patients, then why are you going to expose unaffected children to unnecessary procedures? And the most interesting conclusion is that why are we going to do biopsies if we're not going to change the management? And some other people are trying to do the same approach. They're trying to find a way to kind of navigate this thing using biochemical markers. And in this interesting study in France, they used two big databases, one to do the study and one to validate. And using linear regressions and multivariate regressions, they used ALT as one of the surrogates to detect liver disease. So they found that an ALT greater than 53 can guide you to obtain a liver biopsy. Prior to that, they postulate that they need to do an ultrasound, and if the ALT is greater than 53, a liver biopsy is indicated. And when the ultrasound is positive, but you don't have a level of those transaminases that high, then you can either do it a systemic liver biopsy, or you can do another mode like elastography to detect if there is fibrosis. So they are concluding that maybe a selective approach is better. And again, as I just said, 256,000 operations in the United States with about 2% of the complications. That is a lot of people that can have issues with hematomas and perhaps even bioleaks. So we need to consider, and my approach will be to be selective with the liver biopsy. So in conclusion, I think the diagnosis of liver disease in patients with metabolic syndrome can be challenging, as we just saw. Bariatric surgery is a powerful tool to treat liver disease. There's no compelling evidence to do a routine liver biopsy. And the main utility of intraoperative liver biopsy during bariatric surgery lies in a diagnostic power rather than a direct effect on the postoperative management. Liver biopsies does not impact the management. While we're doing bariatric surgery, we are already treating the disease. And I know some may argue that in some population, and about 4%, you can increase or exacerbate the liver disease to the point of liver failure, but that can be, but that's debatable. The reality is that more of the studies are needed, more prospective studies, well-designed, with big sample sizes need to be done in order to address this question. My personal practice is to do this procedure selectively. And with that, I want to thank the SSAT and Dr. Verdaro for the opportunity to talk today, and I am happy to take questions.
Carla?
Okay, wonderful. First of all, thanks all of our panelists. Those were really incredible talks. And even as a moderator, I've been sitting here jotting down my own questions. I learned so much from everybody. And I think just open to everybody in the audience, if you do have a question, please feel free to put that in the chat or the Q&A. But I'm going to start us off because I do have a few things I wanted to ask our panelists. So number one, going back to Ian's talk, I was a little surprised, maybe I shouldn't have been, but I didn't realize that there are actually no indications for ever to get a surveillance gallbladder ultrasound on anybody. And I do find myself tending to go toward that for patients who want to bypass. And I guess I'm just wondering to our panelists, everyone can speak up, do any of you get routine surveillance ultrasounds for your bariatric patients or no?
Oh, I don't routinely get
everyone move their heads.
Okay,
go
so
ahead.
Yelene's no. Anybody else? Anybody get them at all?
I don't routinely get them.
Okay.
I don't need it.
No.
So I wonder where I am as a referral center, we get, anyone who's had a bypass who has gallstones, I feel like is transferred into our center. And maybe I have a little PTSD from all of the post-bypass patients with choledochal lithiasis. So I guess my follow-up question to everyone, when this does happen and you have a gastric bypass patient with choledochal, what is your go-to maneuver? Is that going to be your lap-assisted ERCP, an edge procedure, or have IR? I'd kind of like to hear from other panelists what you guys all do. I personally, lap-assisted ERCP, though I will say, while it sounds easy, I find while we're doing it in the operating room, it seems to be a little bit of a cluster trying to get the endoscopists into the operating room and get their scope in. So I just wonder what others' experience are with that.
I can start. We routinely do lap assisted. We have a good dynamic with our interventional gastroenterologist and have a good setup, so it works really well. The axial stent and that the edge procedure with the GG fistula always makes me nervous to hear that anyone's doing that, because honestly, does that fistula actually close after you take out a stent? So, I've even had those conversations with our interventional gastroenterologists because they have such a good working relationship with us. So I think it's easy for them to say, we don't do that. And so they've even asked what our opinions are about that. And, personally, I feel like that just can't be a good idea. But it sounds like it's a great way to use the new technology we have to do a different kind of non-invasive intervention. But generally doing a lap-assisted ERCP is not too invasive, and if we feel like the patient's going to need repeat ERCPs, we just leave a G-tube there, and they can access the remnant later.
Sergio, I think we have a new controversy here.
Yes. Well, let me tell you also, it's not that easy sometimes to find the gastric remnant if the patient had an open gastric bypass. So usually my patients, they never read the book and they don't make it easy for me, So, and you are always afraid because sometimes you have no access to the prior operative report. So you don't know where is exactly the ruling. So it's not that easy. So.
Yes. We actually have a question in our chat function here from Jonathan Carter saying, to our panelists, if you have a patient with known gallstones and you're booking them for a gastric bypass, do you change anything? Do you add a cholecystectomy onto your procedure? And I can start. I will answer that question. I will say, I will strongly sort of tell the patients all the things that can happen if we do leave a gallbladder with gallstones in. And especially if they're a symptomatic patient, I will definitely recommend getting the gallbladder out at the time of surgery. So I'll open it up to everyone else as well.
In that case, we'll definitely consent the patient to go in and get the gallbladder out. And then in the OR, we'll make the assessment. If it does look inflamed or has some of those ventral adhesions that are terrible, then you have the answer. But our approach is a little bit more conservative.
I would agree with that, Carla. I tend to really only pursue that in patients who are symptomatic. Other than that, if there isn't anything obvious, once you put the scope in, we too would be conservative and leave the gallbladder alone. I think there's been a good bit of data that shows that these patients aren't necessarily the ones who ultimately become symptomatic and do need the gallbladder out in the long term. So that's the practice that I've had for a number of years.
Jan, any opinion about that? You are the expert in the panel.
So this is actually a continuation. So this is actually a continuation of a discussion I had over lunch with my partner, John Carter, who posed that question. So I look at it as if a patient is symptomatic, then definitely that is a patient who would get their gallbladder out at the same time. And if they're really symptomatic, they might get it out before they get the gastric bypass. For a patient who is asymptomatic, given that only about 3 to 5% of these patients will proceed to needing a cholecystectomy, I have been also similar to the panel, leaving these patients with their gallbladder in and not doing anything at the time of surgery. However, I think some of the nuances that we have to consider, what are these patients coming from 3-4 hours away? Will this patient have access to a surgeon who can manage their gallbladder disease down the road? So I think there are some small nuances that we have to think about. Also, if this is a patient with multiple tiny stones, even if they are asymptomatic, that might be a patient I would consider taking out the gallbladder at the time of surgery, because they most likely have a higher likelihood of dropping those stones than someone who has a 2-centimeter mobile stone in their gallbladder, who more likely will just present down the road, likely with biliary colic. So I think, in general, I probably would leave these patients alone, but there are certain small nuances that I would look into.
Ian, how would we know that if we didn't get the pre-op ultrasound?
Oh, that's the thing, I don't. Again, there's a lot of nuances here. Again, since I don't get them, so I don't. But then let's be honest, a lot of these patients, when they come to the office, most of them will have a CAT scan or an ultrasound that they come in with already, and they're like, "Hey, I had this ultrasound with gallbladder with stones. Can you take my gallbladder out at the same time?"
Yeah, I think that's a really good point. I feel like a majority of my patients have been seen in the ER for another reason, and the information is there, and then I'm left with what to do with that. And yeah, we all make our decisions as we do. So here's another question. It's come up in the Q&A. This is interesting. I'll be interested to hear what people say to this. Is an intraoperative cholangiogram indicated if you're doing a concomitant cholecystectomy with Roux-en-Y? I think probably the similar indications that I would think for anybody else, if I'm going to do a pre-op IOC, based on LFTs or common bile duct dilation, if you had an ultrasound beforehand. But I would say I definitely shy away from doing one of those during a gastric bypass, because I feel like that case was already long enough as it was, and then adding a gallbladder along with it, plus a cholangiogram. So anybody else have any thoughts?
Well, I have to jump in because Dr. Pump is my mentor. I remember him telling us, it's better that you do something, for example, a cholangiogram routinely, because when you need it, you cannot do it if you don't do it routinely. That's usually what happens, right? Usually when you need it, it's difficult, you cannot cannulate, etc. And it goes with the logic of those trying to do the gallbladder surgery during the gastric bypass. Well, you want to check that you are not leaving any gallstone behind. 5% of residual stones on the CBD is something that we can expect, right? So my preference is we have symptomatic patient with the gallstones. I do the cholecystectomy first, recover, and 4 to 6 weeks after, I perform the gastric bypass.
Yeah, I agree. My practice is if they have symptomatic gallstones, then oftentimes they have multiple requirements from insurance anyway. So we'll do the cholecystectomy first and then the bariatric surgery later. But if they're asymptomatic, again, leave that. And so I think I agree with you, Carla. Same indications for cholangiogram as usual. I don't think in that situation I would routinely do, but I do appreciate Sergio's enthusiasm for routine cholangiograms. I know that's another controversy to talk about resident training and training our trainees to do cholangiogram.
Let's see here. I know we're getting close to the end.
Quickly, from the perspective of someone who does, I've switched from a laparoscopic to a robotic approach over the last 7 years for bariatrics. And I do routine ICG. Now, obviously, that is not going to check for stones in your common bile duct, that's just to identify anatomy. So that is a different perspective there, but I just want to say that, for those patients, it is, logistically sometimes can be a challenge to do an intra-op cholangiogram. So I just wanted to put that out there. Although it has been described by some people, it's not always, easy to do an intra-op IOC in patients who are undergoing a robotic bariatric procedure.
Okay, like I said, I know we're kind of running out of time, but I'm going to use this opportunity, since there aren't any other questions, to maybe just kind of poll the panelists here about my own patient. And basically based on Dr. Gibbs' talk on this ventral hernia, I have a patient coming up, BMI 50, has about a 6 centimeter periumbilical hernia, loop of bowel that, will kind of come and go through it. And I'm getting her set up for a sleeve. And I'm trying to think to myself exactly how I want to tackle this hernia, because I do know if I do nothing for it, she probably has a really high risk of having a post-op issue. If I do a primary repair, trying to get 6 centimeters back together in a BMI 50, tough. So then we're left with mesh. And are you going to try to do some sort of laparoscopic IPOM, maybe, because you don't want to burn any bridges for a good repair later down the road? And so I'd kind of be interested to hear what other panelists would do in this situation. Maybe I'll start with you, Dr. Gibbs. What would you do?
Oh, perfect. I think you already walked yourself through.
I thought about it a lot, actually.
To the recommended answer, and I think it really goes back to the point when you're doing these operations. They're significant in operations in and of themselves, and when you start thinking of adding a second operation, as we were just talking about, you went from the gallbladder to then doing the IOC. A hernia repair can be simple and, add another 15 minutes, or it can add a significant period of time, depending on it. But I think your point about the fact that there is a loop of bowel there kind of sets the stage for you. Don't want to have that come up as a problem post-operatively. So this would be the perfect patient for a concomitant repair with mesh.
I know. I always, I don't enjoy a coated mesh, especially even though with your data about the sleeve having no bacteria sort of left behind in the peritoneum, that makes me actually feel a lot better. I always get really nervous if I'm going to do an IPOM and there's been any sort of chance it could get infected. But I think maybe that'll make me sleep a little better at night knowing that. Would anybody else do anything differently? Maybe an open approach? Would anybody just kind of try to cut down on it?
I have the tendency to stage the hernia repairs. It's a difficult decision. If there's bowel and it's a full myriad of symptoms, then I might do something different. But my approach is that hernia has been there for a while. It's 6 centimeters. Is not acting up acutely. So it's better to wait 6 months and do one hernia repair. I unfortunately have the joy of doing reoperative hernia a lot, and going into a reoperative field in hernias and removing meshes and all that is painful. So I tend to finish the sleeve, counsel the patient well about the incarceration signs and symptoms, and then wait a prudent time, 6 months, and do a close follow-up, and then do a reap stop or something along those lines, preferably lab, or robotic. But I tend to stage most of the hernia stuff.
Carl, one of the other things that I didn't mention is that there are some people after they've reduced that hernia, they'll put in an omental plug, and then defer to a better time.
Yeah.
Hey, and
you took one of my answers, Karen.
Yeah. Well, and that's.
But Karen, you were predicting the next question. Yeah, that was actually the question in the chat about an omental plug, which I also do. Yeah. If the plug comes out during the case, I put it back in and put a suture on it. That way it stays in place.
Okay.
But here there is another circumstance that has to be taken into account. If the hernia never obstructed and is not on the way of the operation I have to do, I leave it alone. I leave and fight another day when the patient is in better condition. One problem is when the hernia is on your way. So if the hernia is on your way, that's different because eventually you have to take care at the same time. Sometimes you can accommodate a little bit and try to put your trocar on more lateral side or things like that.
I'm really good at ignoring hernias. I can tell you.
But the option of for a safer content plugging with the Omenton is usually a 50 of BMI. We usually have experience that we have plenty of stuff to plug the hernia. So
That's it.
So, Carla.
I'm surprised that in a BMI of 50 that bowel managed to find its way.
I know. It is really special.
Just momentum. But I agree with everything said. I mean, I try to push patients as long as I can for their hernia repair. If I can get them to weight loss surgery first. I mean, oftentimes our situation, it's like redo hernias and the patient's BMI is 55 or 50, you know. So yeah, you try, but that sounds like a tough situation.
Yeah.
So Carla, I think we are running out of time. We would like to do the final remarks. So I will give you first the opportunity to you.
Yes, well, like I said, I've learned so much from you all, and I appreciate everyone who took time to look up everything and present all of these facts to us tonight. And yeah, so I appreciate you all, and thank you very much.
For me, the same. You five are very talented young physicians and leaders in our society. I really thank you all. I thank the leadership of our society that actually promotes these educational webinars. To Dr. Andreas Kaiser, that is our chairman in the PG CME committee that also supported this webinar. Amy O'Keefe, that had been the greatest organizer to put all of us together. We appreciate, Amy, all your hard work. And I would like to enthuse all the participants and all of you in the panel that you have residents to enthuse them to participate on SSAT. SSAT had become an even more dynamic society, and we want young people, talented like you all, to participate. And this is a good opportunity to enthuse your residents that actually they can develop an academic career with the help and support of the leaders of SSAT. So I think it has been an honor to be the co-moderator with Dr. Holcomb and to see very talented leaders on our field that I had the pleasure to have also a very friendly relationship. So thank you again to all. And I hope you have a wonderful holiday season. And thank you for joining us. Have a wonderful and healthy night.
Bye, everyone.
Bye, thank
Advance happy birthday, Sergio.
Yes, happy birthday, Sergio.
Yeah.
Bye.
Thank you. I'm getting younger.
Happy birthday.